Cek, cek, 1, 2, cek. Cek, cek, 1, 2. Cek, cek.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, distinguished guests. Our guest of honor from Duke Eye Center, Prof. Lloyd Williams, MD, James Tian, MD, Dr. Shin Song, DO and teams. Head of Ophthalmology Department, Dr. Ari Jatikusumo, Consultant of Ophthalmology. Head of Corneal Transplant Collaboration Program, Dr. Farabi Marta, Consultant of Ophthalmology. Head of the Eye Bank Cipta Mangunkusumo National General Hospital, Dr. Rina Ladistianora, Consultant of Ophthalmology, and all respected professors, esteemed colleagues, and fellow ophthalmologists. Welcome back to the day 2 of the Corneal Transplant Collaboration Program. Yesterday, we explored posterior lamellar keratoplasty. Today, we will continue with anterior technique and more on hands-on learning. And for today, we will start our session with a lecture on best practice in anterior lamellar keratoplasty presented by Professor Lloyd William, MD. And this session will be moderated by Dr. Farabi Marta. Allow me to introduce our moderator. Dr. Farabi is a cornea, cataract, and refractive surgery consultant in Cipto Mangunkusumo Hospital. He completed an internal fellowship in cornea and anterior segment disease at Hatam Al-Anbiya Eye Hospital in Mashhad, Iran in 2018. He further honed his surgical skill through the pan-corneal surgical workshop at the prestigious L.V. Prasad Eye Institute in India in 2022 and a clinical observership program in the cornea division in Kyoto Prefectural University, Japan in 2023. Dr. Farabi is also the founder of the Fara Eye model, the Fara Eye model scleral fixation, and the Martha technique for modified Yamane IL fixation. He is an active member of leading ophthalmic societies, including INA CRS, APA CRS, ESCRS, and ACS. Dr. Farabi, the time is yours.
Thank you, Dr. Ical, as MC. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone, either in the auditorium and also in the Zoom meeting. Thank you for joining us for these special sessions of Corneal Transplant Collaboration Program. The collaborations between Duke Eye Center, USA, and also RSCM Kirana, Jakarta. My name is Farabi Marta, and I'm very honored to serve as your moderator for today's lecture. This morning, we will explore essential subject in corneal surgery, best practices in posterior lamellar keratoplasty. As we know, the procedure has offered the better, faster recovery for the patients and improved outcomes and also lesser complications compared to the penetrating keratoplasty. And it is my privilege to introduce our distinguished speaker, Dr. Sina Song, DO. Dr. Song, can we show the CV of Dr. Sina? Dr. Song completed her ophthalmology residency at St. John Hospital in New York and went on to pursue a cornea, cataract, and refractive surgery fellowship at Weill Cornell Medicine, New York. And she has been deeply involved in academic medicine and teaching, serving as instructor in ophthalmology at Duke University and Weill Cornell Medicine. And she also medical student education chief at St. John Hospital. And her commitment to ophthalmology community have been proven since she also contribute to the volunteer ophthalmologist Duke Global Ophthalmology in Guyana and also in Mongolia. And today she will share with us her insight on the best practices in posterior lamellar keratoplasty. Following her lecture, we will open the floor for questions. So please feel free to note down anything you would like to ask. Without further ado, Dr. Sina Song, the floor is yours.
Good morning, everyone. Welcome to our third day of this wonderful we had a really interesting OR day with lots of challenging cases yesterday. I know I learned a lot, so I'm excited for today as well. My name is Sheena Song. I recently completed my cornea, cataract, and refractive surgery fellowship, actually this year. And I'm so excited to be back this year. I am now a Duke Global Ophthalmology Fellow. And this year, I'm really excited to learn from you all and collaborate with you all. These are just some photos from our most recent trip where we were in Guyana just a couple of weeks ago, where we were working with the local surgeons there to collaborate together, learn about different eye transplant techniques and learn about eye banking. So I look forward to being here and working with you all today. So I encourage you guys to take a look at this website. This is the Vision Atlas, which is available on the IAPB, or the International Agency for Prevention of Blindness. The website has data on different sort of the demographics and metrics for blindness all over the world globally. And I want to include here some data from Indonesia that I found. So here we could see the demographics of Indonesia, and you could see kind of the burden, the national burden of blindness. In total, about 9 million people of the 280 million people of Indonesia have vision impairment, 2.8 million of which is due to blindness. This is another map that shows sight loss by country. And you could see here that Indonesia has 16% vision loss by population. And just for comparison, so in the US, this is about 4%. In India, it's 23%. This is another chart that shows the different levels of sight loss over time. So again, here you could see it's divided by the different levels of impairment. You have mild, moderate to severe. Near refers to presbyopia, as well as blindness. Here this shows about 3.7 million in Indonesia have blindness. This is a scale that shows the availability of ophthalmologists. And in Indonesia, this is given as per million. So in Indonesia, there's about 5 ophthalmologists per million people. For comparison, in the US, we have about 55 per million. And then here's another comparison to South Sudan. Dr. Lloyd Williams does a lot of work there. In South Sudan, there's about 5 total ophthalmologists, which is less than 1 per million, hence the 0. The really nice thing I noticed about Indonesia was that there are secondary providers, including optometrists and other physician extenders, which make a big difference for the ophthalmology workforce as well. We saw this map yesterday looking at the different causes of blindness. Corneal blindness tends to be the 4th or 5th leading cause of blindness, depending on which source that you look at. And this is an infographic map released by Sight Life, which is a global nonprofit organization whose goal it is to eliminate corneal blindness. So here you could see the country size represent the amount of corneal blindness. And so you could see certain countries, several of those are in Africa, for example, are much larger. And that reflects the amount of corneal blindness in those countries. But then you could see that the colors also represent the country's readiness for addressing corneal blindness. So for example, you could see India here is proportionately much larger. They have a high degree of blindness due to corneal pathologies. However, they are also highly available for addressing corneal blindness. And this is through, of course, there have been many different programs in India in the past couple of decades that have increased the number of trainees as well as increase their eye banking capacity. We saw this slide yesterday, looking at corneal transplantation worldwide. So these statistics are from JAMA Ophthalmology, this was published in 2016. So these numbers have increased since then. But about 185,000 corneal transplants are done worldwide. And of those, 6% are penetrating keratoplasty. Of course, this number is going to change as globally we're starting to see an increase in the number of endothelial keratoplasties. You see that the rate of PKs is reducing, and that's due to both the increase in EKs that are done, but also in the case of keratoconus, we now have cross-linking that's reducing the need for PKs. In 2023, the Eye Bank of America showed that endothelial keratoplasty is now the most common transplant done in the US. And we did about 33,000 endothelial keratoplasties just last year. When looking at the graft rejection rate, so we know that the cornea is immune privileged, and this is of course because the cornea is non-vascular and non-lymphoid. When we look at the different rejection rates, this goes down for your endothelial keratoplasties. Our rejection rates are about 20% for PKs, 7% for DSECs, and 1.5% for DMEC. This slide again shows the different types of transplants. So when we look at our corneal anatomy, we can divide it into, you can have a full thickness penetrating keratoplasty. You can have your anterior lamellar keratoplasties. The difference between ALK and deep ALK, of course, is that in deep anterior lamellar keratoplasty, we're going all the way down to Descemet's membrane, as we saw yesterday, whereas in ALK, you are leaving some residual stroma. That brings us to our posterior lamellar keratoplasties, or DSECs and DMECs. And again, the difference is that in DMEC, you have just Descemet's membrane, a much thinner tissue, compared with DSEC, where there is some stromal tissue. These are some anterior segment OCTs. So figure A shows, this is a patient with some corneal edema and some due to pseudophakic bullous keratopathy. In slide B, you could see that there is a full thickness PK. Slide C shows a DSEC. And slide D shows a DMEC. So you could see in the last picture that the DMEC tissue is so thin that sometimes it's really challenging to even tell that there's one, at least by anterior segment OCT. Okay, so we're going to move on to the meat of our presentation, of course, which is a posterior lamellar keratoplasty. And so when thinking about EKs, of course, this is for patients who have endothelial disease without severe stromal scarring. The question we always wonder is, when do we choose DSEC over DMEC? And of course, because DSEC is it's a thicker tissue, it's a little bit more formidable. So in general, we choose DSEC in corneas where the visibility may be more challenging. And that's because the DMEC tissue is so thin that it may be difficult to visualize despite using trypan blue. And then, of course, in patients with any complex anterior segment anatomy, so for example, those with glaucoma tubes, those who are aphakic, or those who have synechia, for example, we may choose a DSEC over DMEC because the grafts are a little bit more rigid. So when looking at outcomes between DSEC and DMEC, I wanted to share two different reviews that look at different outcomes. To this date, there are no prospective randomized controlled trials that have studied the differences in outcomes between DSEC and DMEC. But this is a Cochrane review that looked at 4 different studies and compared the effectiveness of DSEC versus DMEC in the treatment of pseudophakic bullous keratopathy versus Fuchs endothelial dystrophy. The main outcome was visual acuity, and the other secondary outcomes included endothelial cell count, primary graft failure, graft rejection, as well as graft dislocation. One of the studies I looked at in this trial was a study that looked at 72 people in which they did one eye with a DSEC and the other eye with a DMEC. And in the study, they looked at patients who had Fuchs endothelial dystrophy. And what they found at 1 year was that in general, DMEC had a better visual acuity outcome compared to DSEC. However, there was also a higher rate of graft dislocation in the DMEC group. Otherwise, the endothelial cell count was similar, and same with the graft rejection and failure rates. And this is another study that was done in Germany. This looked at a 10-year outcome comparing over 2,500 eyes in patients who received either a DMEC, DSEC, or a PK. You could see here that they actually reviewed over 7,000 eyes, but then isolated patients who just had Fuchs endothelial dystrophy. These graft survival. So interestingly enough, this study showed that PK had the highest graft survival rate compared to your DSECs and DMECs. And then interestingly enough, when you look at the rejection rate, so again, earlier I shared data showing that DMEC had the lowest rejection rate, followed by DSEC, and with our PKs having the highest rate. This graph here shows that the DMEC had the highest rejection rate, followed by a PK, then DSEC. Here we can show that the visual outcome was improved in our endothelial keratoplasty compared to PKs. So regardless, whether to do a DSEC or DMEC, this is, there's a lot of different kind of opinions on this, but again, when you think of surgically, which one is better to do, you want to choose a DSEC in eyes that generally have poor visualization, as well as eyes with more complex anterior segment anatomy. Okay. So let's look at some surgical videos. So in both DSECs and DMECs, we do a step called decimetorexis, which is when we score the Descemet's membrane. So here you could see that we've marked the cornea with a 8mm optical zone marker. Yesterday, we also used just calipers, and you can mark kind of an 8mm zone. You want to fill the eye with OVD to ensure anterior chambers stability. And here, this is Dr. Lloyd Williams operating, but you could see here he does kind of these two C shapes to score the Descemet, and we do it twice just to make sure that the Descemet's membrane is really scored. Though, of course, yesterday, I think in our first patient, we saw we just really needed one scoring to get a good decimetorexis. But here you could see that kind of using this motion that's similar to capsulorhexis, you're removing the Descemet's membrane. And then here in this video, you could see we have a really good red reflex, so it's very easy to see the Descemet's membrane. But something that we did do for our patients yesterday is we did trypan blue, which is oftentimes not needed, but especially in eyes where you have poor visualization, it's something that could be helpful. Really important to make sure you completely remove any OVD at the end of this step. One, any sort of residual OVD will make the graft manipulation much more challenging, and you're not going to be able to form a bubble very easily either. Okay, so let's talk more about DSEC. So remember, DSEC is a little bit thicker. It has some stroma in addition to the Descemet's membrane. Here the slide talks about using 2 to 3 sutures to close the wound, and it really depends, of course, on how large your wound is. If you use an endosuture or a sheets glide, you are going to need a larger incision, about 4mm. So in this case, you may use 1, 2, or 3 sutures in order to ensure a good wound closure. Again, these tissues are a little bit thicker, and so they can be done in more complex eyes. For example, those with aphakia, those with iris problems, or those with glaucoma tubes or other hardware, for example. Here it talks about using air or gas to put in an air bubble. Okay. So this is a video that demonstrates the use of an endosuture. So this is a patient who had a previous DSEC, and so we didn't need to score it. We were able to just kind of pull it out. But this is an endosuture device where you need to enlarge the wound to 4mm. And you could see here that the endosuture actually needs to be completely inserted to the other side, which is different than an IOL injector, for example, which just stops at the wound. In this video, we are using a sheets glide instead. So again, we're going to enlarge the wound to 4mm. And here we are placing the graft on the glide, and you're using a 30-gauge needle. This is using a push-pull technique where you're kind of essentially pushing the graft into the eye. And then, of course, yesterday we learned how to use a Busen glide, which I personally had never used before. So that was a learning opportunity for me as well. But here, this is a really great instrument to use. You basically are going to line the graft endothelial side up in the injector. And you could see here in the picture in slide D, you're creating an incision about 180 degrees opposite to the wound. And using microforceps, you're going to go through that incision, also go through the wound, and you're using forceps, you're using this pull-through technique to pull the graft into the eye. Okay, so let's move on to DMEC. So DMEC is a much thinner tissue. Of course, there's no stromal, so it's just Descemet's membrane only. So the benefits of a DMEC is that it leads to a quicker recovery, oftentimes improved visual outcome, as we saw with our two previous studies. There is a much smaller risk of rejection. However, it is much more technically challenging, and of course, the tissue is much more friable. So here is a DMEC loader. So there's a glass cannula here. In this case, it's a modified Jones tube. And this is one of the most important things when loading this. There's different ways to do it, but you really want to make sure that there's no air in the tube. And so you could do this underwater, which is what we did yesterday. And then in terms of the syringe, so this is a 3 millimeter syringe, but just know that, you can use a 5 millimeter syringe as well, but a smaller syringe will give you a little bit more control. So this is a photo that I took from Cataract Coach. If any of you guys watch the videos of Dr. Uday, this schematic was done in conjunction with Dr. Veldman from the University of Chicago, and something I found very helpful in helping to understand how to manipulate DMEC tissue. DMEC tissue, doing a DMEC is very elegant. You are essentially moving the tissue inside the eye without directly touching the tissue. And so the way I like to think about it is that you are you're manipulating the fluid inside the eye rather than moving the tissue directly instead. So I included this photo of an avatar water bender because I want you guys, when you guys are doing your DMEC surgery, as DMEC surgeons, you want to channel your inner avatar water bender because you are really, again, working with the fluid dynamics. You are manipulating water flow rather than directly moving the tissue itself. Okay, so let's talk through a couple of the most common configurations. So one of the most common configuration you'll see is a scroll configuration. So if you have a piece of paper here, it's simply a single scroll like this, okay? And the idea is that you want to use fluid waves to open the scroll. So by kind of tapping kind of down the center, if you tap down the center, the water is going to go down the scroll and kind of open up the scroll. Okay, so again, you're not tapping on it, you're kind of using water fluid waves, tap, 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 and the water is going down the scroll and that kind of opens up the tissue. And you could see here in the photo, they're using the cannula again to kind of tap at the mouth of the scroll. Okay. So this is another configuration where you're looking at one-sided scroll. So for example, if you have a paper that's like this, and you have one side that is scrolled like this. So you're actually using two cannulas here. So the first cannula is actually just holding this side down. So you're putting pressure on the water to hold that side down. And using the second cannula, and this is called the Durzimer technique, but you're using the second cannula, again, you're creating fluid waves to propagate fluid to open the scroll like this. Okay, so again, there's two cannulas, and the first one holding the tissue down. The second one, you are kind of propagating fluid waves through the scroll, kind of opening it up like that. This is a double scroll. We like seeing this configuration because it's quite easy to open. So again, if you have a double scroll like this, and we like, this is kind of the ideal way to load it in the cannula, but it doesn't always come out like that. But let's say you have a scroll like this. So the idea is that by tapping right on top, again, you're pushing fluid waves to then propagate and open the tissue like this. Okay, so again, if the tissue is double scrolled like that, you're kind of going right on top, and that opens up the fold. We can go ahead and turn off the lights again. So what do we do here? So these are both configurations that we generally don't like to see. So the first on screen right, you have a tissue that's upside down. You could see that there is a backward S configuration. We mark the tissue sometimes with an S or an F, or yesterday we used 3 lines to show the orientation of the tissue. Of course, you want the endothelial side down. So what do we do when we see this on the left side? And then similarly, what do we do when we see the photo on the right side? So on the right side, we have a graph that's very confused looking. It may be crumpled. We don't know what to do in that situation. So the answer here is to use BSS. So you're actually injecting it parallel. So you're injecting BSS into in your side wound, and the key is to go parallel to the iris. When you go parallel to the iris, you're creating a fluid wave that essentially is able to flip the graft over. And then over here, when you have this origami pattern or a pattern where you may not know which side is up, you don't know how it's folded, the key is just to inject some BSS, and that helps to deepen the chamber, and that will help to kind of reorient the graft. Okay. So let's watch some more surgery videos. So the first thing to note, well, we missed it when we were, well, I want to go back to when we're injecting it. So the first thing to note is that the tissue is very sensitive to movement. You have to be very careful when injecting it because it will go in faster than you think. So again, you may want to use a 3 cc syringe instead of 5 cc. That gives you a little bit more control. But notice how quickly the tissue kind of flies into the eye. So be very careful about this. The next thing that you'll notice is that we're using the cannula to kind of shallow the chamber. So you want to do this to prevent the shift in pressure difference. If you have a high pressure in your anterior chamber, your tissue might come flying out of the eye, which we don't want to see. So it's super important to shallow the chamber immediately. So you could see that we're doing that again here, where we're shallowing the chamber. And then here, so this is that Dirizimer technique where, again, you're using the cannula on one side to hold the tissue down and then using a series of taps. So you're, in this side, they're actually creating kind of a vacuum, but you could also kind of tap that scroll. And again, you're creating fluid waves to move the graft. All right, so here's another video, and note here that the patient is constricted with pilocarpine, and this is important because of course you don't want to lose the graft, you don't want it to go posteriorly. And again, watch the tissue go inside. You want to be very careful when injecting it. Here again, you see that they're shallowing the AC to decrease the pressure. There, and again, you're shallowing the AC even more, and you're using the cannula to actually hold it at the wound because this prevents, you don't, again, the last thing you want is for your tissue to come out. So again, here we have one tissue side that's flapped over. And so the first thing that they're doing is they're actually translocating the tissue. We'll talk about that in just a bit. But now we're, again, using that Dirizimer technique where you're holding one side down and using the other cannula to kind of tap it. You're creating fluid waves to unfold the tissue. And the next part is to how do we move the tissue? So there's 2 ways to do that. So if your tissue is like this and you're trying to move it that way, the first way to do it is to kind of tap it. And again, the idea is you're kind of creating a fluid wave to translocate the tissue. So really kind of a hard tap. And then the other way here, so let's watch that first, is you're actually going on the other side. And the idea is that you are displacing fluid and almost creating a vacuum. So if we kind of displace fluid here and then quickly remove your cannula, that kind of creates a vacuum and displaces the fluid. So again, to move the tissue, one way you can either tap directly as if you're pushing the water and pushing it in the opposite direction, or you can go on one side and kind of very quickly create a vacuum to move the tissue in that direction. So here we could see they're doing that. So there you go. You're kind of displacing the fluid and dragging the tissue with it. or you can tap it on the other side. Now it's nice and centered. You can see that we have an S, so we know that the configuration is correct as well. Note here that there is a bubble, which we don't like to see. So always be very careful about making sure that there's no bubble in the cannula. And if you see bubbles like that, you do want to remove it. It's not clear, this bubble might be under the graft, but definitely if it's in between the graft and the cornea, you want to go in and remove that. Sometimes you can kind of squeegee it out as well. Okay, so here's another one that is going pretty smoothly. You could see we put the graft in, we're shallowing the chamber. We're using a variety of tapping techniques to open the tissue. Looks like we started with a scroll pattern and our tissue is nice and centered. And then here you can see, oh, nope. So you could see, I'm guessing this is a fellow and maybe Dr. Williams. We're going to watch that again, where our tissue is kind of in a nice shape. And you have to be very careful. So you don't want to inject BSS too quickly because that can lead to what we call an origami pattern, where the tissue is in an unclear configuration. And so when you deal with a situation like this, you want to inject a little bit more BSS, which is what we're doing here, and that helps to kind of reorient the tissue. And then we keep doing that until we have a configuration that's recognizable and one that we can unscroll using our different cannula techniques. Okay, and then once our tissue, once we're happy with the position, then of course we're going to put either an air or a dilute gas bubble. And so in the beginning, we try to get close to a 100% air fill as seen here. And you want to do that to just really make sure that the stroma adheres very tightly. And then usually after a couple of minutes, you'll want to decrease that air bubble. And usually we shoot for about an 80% to 90% fill. And usually I just look to make sure that the bubble is just kind of beyond the graft. We don't want it too big, of course, because that can send the patient into pupillary block, for which we'll do a prophylactic inferior iridotomy. So once this is done, we're going to have the patient face up. And usually we do this for about, the bubble will usually last for about 24 to 48 hours on average. So depending on if the bubble is still there and what kind of gas you're using, you can counsel your patient on face-up positioning. Again, we could use air or gas. The benefit of gas, of course, is that it lasts longer. But again, you want to make sure it's dilute. You want to make sure you don't send your patient into pupillary block. And so you don't want to fill too much, and you want to make sure you have a prophylactic peripheral iridotomy. Okay, so in terms of our post-operative drop regimen, so we often counsel our patients before they have a corneal transplant that we may be committing them to a life of drops. In the very beginning with the transplant, you want to be very aggressive. So typically we'll prescribe prednisolone, usually every hour for the first week or so. And then we do a very, very slow taper. So this is the regimen that we usually give to our patients. And then here at the end of it, sometimes we'll keep our patients on prednisolone once a day for life. Sometimes we'll try to transition them to a lower dose steroid, such as fluorometholone or Pred Mild or loteprednol. And again, we usually have them on a low regimen like that, one drop for the rest of their lives. We talked about a pupillary block. Again, you want to make sure, don't forget that peripheral iridotomy. Make sure your bubble size is correct. High eye pressure is a common problem that we see in these patients. And so you want to make sure that you monitor their pressure very carefully. In terms of rebubbling, so in general, well, I'm curious, Dr. Williams, what your gauge is, but typically if the graft is 70% attached or more, we usually monitor that. But if they have a 30% detachment or more, we'll consider rebubbling them in the clinic. Is that what you do, Dr. Williams? Okay. Yeah. Okay. Yeah. So Dr. Williams had just said that it kind of depends on how the vision is, if there's edema, also looking at where the detachment is. But sometimes, these are things that can also be monitored. We don't have to act right away. See how oftentimes, even if there's a little bit of a detachment, you may see that somehow the graph finds its way to where it's supposed to be and will kind of attach naturally. So just looking at some of the other procedures that we're starting to do more. So one of them is decimase stripping only, or DSO. So this is indicated in patients with Fuchs endothelial dystrophy. And you have to make sure for these patients that they have enough endothelial counts. So usually for these patients, you may see that they have a lot of guttae in the center, but you'll see that they have a clear peripheral endothelial cells. And you want to make sure that their endothelial count is at least 1,000. And so for these patients, you'll see here, we make a much smaller decimeter rhexis, about 4 millimeters, right in the visual axis, leaving, of course, enough peripheral endothelial cells. And the ideal patient to do this on is, again, a Fuchs patient who has decreased visual acuity due to the guttae. So usually they'll have glare, will have photophobia, but not decreased vision due to corneal edema. Because usually, if they have corneal edema, at that point, they don't have enough healthy endothelial cells. There's a lot of other exciting things on the horizon. So one of them is EndoArt, which is an artificial corneal endothelium. So this is a biocompatible hydrophilic acrylic plate that's implanted. And the idea is that it's basically replacing the disease endothelium while still providing peripheral fluid exchange. And so this prevents corneal hydration by acting as an impermeable barrier to aqueous flow. There's a lot of other developments with corneal cell therapy as well. So essentially, these are, we are harvesting endothelial cells from cadavers, just like we do for our corneal transplants. And these cells are then grown in vitro. So one of the companies that's looking into this is Orion Biotech, where they're harvesting these endothelial cells and injecting it into the AC. We combine it with a ROCK inhibitor, and these patients have to face down for 3 hours. There's also MSL cell therapy, which I thought was fascinating. But essentially, these are actually magnetized endothelial cells. So these are injected into the AC, and you could see here that an external magnet is placed to kind of bring the endothelial cells to position. The beautiful thing about this is that no positioning is required, and this can be done outside of the OR. So there's a lot of exciting things in the pipeline with endothelial therapy. Okay. So that's it. Thank you so much for your time and your attention. I'm so grateful to be here. I'm so excited to learn from you all and collaborate with you all over the next day rather. And these are some helpful links that I think Dr. Williams shared yesterday. There's some great videos on the Moran Core website. These has, especially for all you residents out there, it's a great resource that has surgical videos, not just for corneal transplants, but cataract surgeries and other procedures as well. This was very helpful when I was a resident. We have Dr. Williams' email and my email as well. Thank you. I'll take any questions.
Thank you, Dr. Sina, for the wonderful presentations and also the videos. So do you have any questions regarding the topic?
Good morning, doctor. Thank you for your great presentation. I'm Fabi from second stage. I would like to ask about DMEC and DSEC. How do long-term outcomes such as endothelial cell survival and graft rejection rate compared between DSEC and DMEC in your experience? In terms of endothelial cell loss, do you find a significant difference between DSEC and DMEC in the long-term follow-up? Thank you.
Okay. Thank you. That's a great question. So I'll turn your attention back to this slide because I don't think there's any clear answer to that question because again, there have not been any prospective randomized control trials that have looked at the different outcomes. But in general, I think the accepted mantra is that the rejection rate is certainly much lower for DMEC than compared to DSEC than compared to PKs. So again, this review that looked at 4 different studies looked at the different outcomes, namely it looked at the visual outcome, and they found that in general, DMEC patients had a better visual outcome over 1 year. This study specifically found that the rejection and failure rate were similar between the two. So again, it's differing results based on which studies that you look at. Dr. Williams, did you have anything to add to that?
No, I agree with that, DMEC seems to have the lowest rate of rejection. And if you can get the DMEC to attach and clear nicely, I can't think of a patient I've seen a rejection take place in a in any near term in DMEC. So my opinion in general is that the most significant challenges of DMEC occur intraoperatively and in the early post-op period with bubble size and getting graft attachment. But if you can get through those stages, generally the DMECs do really, really well.
I was going to add one potential reason why DMETs do well, in addition to the reasons answered, is that, the DSET comes with a little piece of stromal tissue, and that makes it very easy to manipulate intraoperatively. However, that results in a little stroma to stroma interface opacity, and it's not much, but it's just enough to decrease the vision ever so slightly, that at least in the United States, if they are a good candidate for DMET, we generally do DMET over DSET.
And I'll say, a typical DMEC patient will be 6'6" or even 6'4.5", and a typical DSEC patient will be 6'9". So if you can do a DMEC, the vision outcomes are definitely better. And there's a paper by Majid Moshafar and I that discusses some of the reasons why we think DSECs don't get to 20/20 or 6'6" that often. But the DMEC patients, I definitely have patients who are 6/4.5 after DMEC bilaterally, and it's really, the outcomes are really great.
Yeah, but for the learning curve, I think DMEC is more technically difficult. So whether they are the primary graft failure, maybe for the first 10 DMEC, do you have that experience in your fellow? Maybe?
Yeah, so I think I'm going to answer your question. DMEC is a bit of a longer learning curve, although once you learn it, my own personal opinion is DMEC is not that hard, as long as you can see into the eye and the eye is relatively normal, if that makes sense. So like post-vitrectomized eyes can be really, really soft, and you shallow the chamber, and no matter how much you shallow the chamber, the whole eye keeps getting softer and the chamber never really gets shallow. And that can make it very hard to open up the graft. Anything in the eye, like vitreous or tubes or other kinds of hardware or pigment or fibrin, all of those make opening a DMEC very hard. And when you can't see very well, it's very hard to manipulate it and open it. You can open a DSEC almost no view at all, because if you put it in the right orientation, it's going to open in the right orientation. So you don't actually really have to see it in order to know that it opened correctly. Whereas the DMEC, you have to pretty much see the whole process. So from that side, the DMEC is more challenging. But when I look at my cases of DMEC and my cases of DSEC at Duke, I actually feel like my DSEC cases are harder cases, because I'm always doing DSEC on a patient who I thought had some reason why they can't do DMEC. So I'm doing DSEC with tubes and no view and Yamani and a vitrectomy and you know, and the eye is really quite difficult. So whereas my DMEC cases are usually Fuchs dystrophy and the rest of the eye is fine. So ultimately, I feel like the DMEC cases for me end up being easier. And I think something that can be sort of paralyzing or difficult when you're starting to think about doing DMEC, and I would recommend your first DMEC cases be, you know, straight routine bullous keratopathy or Fuchs dystrophy where you have a decent view into the eye so that you can build confidence in relatively straightforward cases where you have good visualization. But what I find, you know, you see a slide that shows 25 different shapes that the DMEC can form, and you think, how can I possibly remember how to fix all of these shapes? What I do is, no matter what shape it is, if you refill the anterior chamber, it will want to go into a scroll or a double scroll eventually. And so whatever weird shape it forms, I refilm the chamber, get it into the shape I know how to fix, shallow the chamber, and then open it up. And if it turns out upside down, you can flip it over with the fluid. A lot of times it'll fold up into some weird origami as you're flipping it over. And then you can open or deepen the chamber, get it back into a scroll or a double scroll, shallow the chamber, and tap it open. And so if you can master scroll and double scroll, which are basically about the same, and simple fold, which is like an intermediate step between scroll and double scroll and actually all the way open, then you don't actually have to think about any other way of doing it as long as you know how to get it into that shape. So you learn how to make a scroll and you learn how to open it, and that's about it. So it's actually not that hard once you kind of master it. The other nice thing about training for it is if you get a cornea to work on, you can get 1D mech tissue, unfold it, stick it up, take it down, unfold it, stick it up, take it down, unfold it, stick it up, take it down in the wet lab over and over until you master the concept. You don't need a bunch of different tissues. You need one eye and an artificial anterior chamber, and you can practice this over and over and over again. And I think even your eye model, if you had one piece of DMEC tissue that was nicely stained, I bet you could unfold it in your eye model. That's for those of who can't see who I'm talking to. That's Dr. Farabee's model eye. I would imagine you can unfold it and open it up in that anterior chamber system. And just do it again and again and again until you kind of master that idea.
Thank you, Prof. Because in our experience, we have one patient that we try to unfold it for 1 hour.
Yeah. So there can be a couple reasons for that. One is, well, I'll say there's probably 3 things that can happen there. Number one, if when you're doing DMEC, the tissue can't come from a donor who's very young. So the younger the donor, the more tightly the scroll will scroll. So usually we're doing DMEC with tissue from a donor that's about 50 years old or older. And even a lot of times 60 or almost 70 years old. And so you'll see that if you have like a 65-year-old donor, sometimes you'll put the DMEC into the anterior chamber and it will almost unfold on its own. And then if you put like a 35-year-old one in, it can be a nice scroll and you can tap it and tap it and tap it and it will not unfold. And so it's important to have older tissue when you're doing DMEC. Not older like it's been in the eye bank longer, but older for older donor. Number 2, you have to be careful that there's not something else in the eye that's blocking it. So if when you made your PI, you got some blood, the blood and the fibrin from the blood will just sit as a barrier to the graft opening. And you'll never, ever be able to push that graft open against the blood. So you have to think, is there vitreous? Is there blood? Is there something that's holding this graft closed, like vitreous blood or fibrin? Those will all ruin your DMEC. And in that case, you'll have to, as much as you'd prefer not to put instruments in the eye like a Simcoe, you'll have to go into the eye and get rid of that blood or fibrin, or even vitreous if you're going to open the graft. Otherwise, there's no way you can open it. And then number 3 is just sort of mastering the techniques of opening a scroll or a double scroll. And if you don't have those, you can deepen the chamber, and the tissue will scroll up if you can make the chamber deep enough for it to do that. And then shallow the chamber and start back on that. Sometimes people don't make the chamber shallow enough too. And so then you can get it half open and then it'll close up again every time because the chamber is not shallow enough.
Thank you, Prof. Thank you, Dr. Sina. Maybe because of the limitations of time, we continue to our case presentations. There are presentations for the case that will be performed surgery today, and also the post-operative. We have 3 cases of post-operative patients that we want to discuss.
Morning, professors, doctors, the team from the Duke Eye Center, and fellow residents. My name is Salumi, resident in the Cataract and Refractive Surgery Division. I will be presenting the case review for today's surgical schedule. For today, we have 3 DMECs, 1 DSEC, and 2 ALK plan. So the first is this will be the DMEX procedures. There are 3 DMEX plans for today, 2 using the pre-cut donor and 1 using the donor tissue from yesterday's gulf. So the first DMEC patient is the case of bullous keratopathy of the left eye, suspected due to bee sting toxicity with differential diagnosis of viral infection. This is the latest ophthalmology examination showing visual acuity of 1/300 with good projection in the left eye and 6/6 in the fellow eye with normal IOP. And for the cornea, the left eye appears hazy with edema, presence of bullae, and positive staining. This is the ASOCT of the patient. So the second DMEC patient is a case of fused endothelial corneal dystrophy in both eyes with pseudophakia of the right eye. The patient underwent the surgery of the right eye in February 2025. The latest examination shows the visual acuity of 0.5/60 in the right eye and 1/60 in the fellow eye with normal IOP. And the cornea appears hazy at the central with decimate fall, goutte, and Beaton-Browns appearance. And this is the ASOCT image of the patient. The third DMEC patient for today is with the decompensated endothelium in the left eye and pseudophakic bullous keratopathy of the right eye with fused endothelial corneal dystrophy of both eyes. The latest examination show the visual acuity of the left eye is 1/60 with the fellow eye 0.5/60 with normal IOP. And the cornea show edema, decimate fault, and neovascularization in the inferior part. And this is the OCT of the patient. And for today, we'll have 1 DSEC patient. The DSEC patient is with one eye, pseudophakia of the right eye with post-IOL exchange with Yamane technique indicated for IOL decentration. The surgery was done in on August 13th, 2025. The patient, the latest examination shows visual acuity of 1/60 in the right eye and 6/7.5 in the left eye with normal IOP, and the right cornea shows edema with decimate fold, especially in the central area, and there is one nylon suture at the 12 o'clock position. This is the OCT image of the patient. And this is for the PKP. We have one patient scheduled for PKP today. The diagnosis of the patient is corneal cicatrix with epithelialized iris prolapse with a history of perforated corneal ulcer of the right eye. The patient also has secondary glaucoma of the right eye, but we already given medication on the last follow-up. So the latest examination showed visual acuity of the right eye 1/300 with the fellow eye is 6/6 with IOP 40 without glaucoma medication. And on the examination, the cornea showed a cicatrix in central area, with measuring 6 by 5 millimeters with an epithelialized iris prolapse and also staining of the cornea. This is the OCT of the PKP patient. And the last, we have two ALK procedures scheduled for today. The first ALK patient is with a corneal scar of the left eye with a history of corneal ulcer due to bacterial infection and complicated cataract of the left eye. The visual acuity of the left eye is 3/60, fellow eye 6/6, with hazy cornea, corneal scar in the central and paracentral hemi-inferior region, involving more than half of the stroma, measuring 3.5 by 4 millimeters with superficial neovascularization. And this is the OCT image of the patient. And the last one is the patient with corneal scar of both eyes, recurrent viral keratitis of both eyes. And the patient has already been started on oral aceclofir beginning on Monday, August 25th, 2025, as advised by Dr. James before. The visual acuity of the right eye is 1/60 with normal IOP, and the cornea show a central P-shaped corneal scar with deep and superficial neovascularization with corneal pinning and also positive sensitivity. This is the ASOCT of the patient. That's all for the case review.
Thank you, Dr. Saruni. You have comment, Prof?
Yeah. I noticed that the bee sting patient was listed as the one that was going to be the observed DMEC. I would suggest that we do the second patient, the very straightforward DMEC is the one that's observed, so that people can see a very straightforward case. Since there haven't been a lot of DMECs in Indonesia, I think it's useful to see what you might call a relatively easy case, so that you can see all of the normal parameters, as opposed to the other one where the view might not be very good and it may be a little bit of a struggle. I think it'd be great to see one that is just straightforward with a pre-stained tissue with a nice S stamp and everything looks nice, as the one that we do as the live surgery.
So it will be, these patients will be the live surgery, yeah?
Yeah, I think that one would be absolutely perfect.
Switch this.
Thanks.
Thank you, Prof. And regarding the microkeratom, I think we cannot activate it today. So maybe we should divide the donor manually, Prof. Is it okay? The
What's that?
DSEC and the ALK.
Yeah,
We don't use microkeratom today.
correct. There is one piece of the microkeratome that they didn't send. So we'll figure it out and we'll make
Okay,
sure that,
great.
but we
Thank
won't
you.
have it for today.
Yeah.
So I'll do it manually.
Thank you. proceed to the post-operative.
Okay, we'll move on to the post results from yesterday's surgery. So this is for one DMAC patient and also one DSEC patient. For the DMAC patient, the patient was also given SF6 gas during the intraoperatively with a background of corneal dystrophy of both eyes. On this morning follow-up, the visual acuity is 0.5/60, the same as preoperatively. And then the IOP is 4D, and the cornea is pure hazy with graft attached, slight graft concentration to the inferior, two nylon sutures at the temporal side, and the bubble was positive. We plan to give topical and oral glaucoma medication, and we would like also to discuss whether we need to do decompression for this patient.
So this is the one that I do the surgery with Dr. James.
Yeah. So far, I think this looks great. The pressure is a little bit high, so we'll probably want to let out a little bit of pressure, which will actually make the bubble a little bit bigger because PV equals nRT, if you remember your physics. But the fact that the cornea is pretty clear right now is actually a pretty good sign, and I think it's encouraging and likely that this patient will do well.
Compared to the pre-op picture, like I don't know if you have that pulled up.
Can you give us the pre-op picture for this patient?
The other comment is that the vision should be poor right now because the patient is looking through a bubble. And so the day one visual acuity is nothing to worry about. It should always be bad because they're looking through the bubble. You get a better sense of what their vision is going to be when the bubble has cleared the visual axis and is small enough that they're seeing below the bubble. Then you'll get a good idea of how they see.
So is it normal to give a bubble around 90%, or we should reduce it post-operative?
When they're laying flat, the bubble will look larger than when they're sitting up. So the bubble size in that photograph is great. Usually it's about 65%. That means you have a very good sized bubble because then when they lay down, it will cover the whole graft. When they're sitting up, the bubble might not cover the bottom of the graft, but that's okay. If it's 95%, when they're laying down, they'll be in block and the pressure will be too high.
One comment I made to Dr. Fairby yesterday, just to make sure everyone knows as well, is that especially in pseudophakic eyes, it can be a little difficult to measure, to estimate the total volume of the bubble in the eye because the bubble can be pushing the iris down against the intraocular lens. So you could have what looks like a 90% bubble be actually completely different volumes based on how posterior the iris is. So, that's just something to keep in mind as well.
Yeah, it's not uncommon where everything gets pushed back and you think, oh, I've got a 60-70% bubble. And then as the iris and everything resumes its normal position and moves forward, you find you have a nearly 100% bubble because the anterior chamber is now somewhat smaller. And
so this is the pre-op picture.
This is the one with big lenticle and small cornea.
yeah, so the cornea is already clearer, right? So I think that's a very good sign. Usually if the cornea is clearer, you're moving in the right direction. Now the bubble can make the cornea a little clearer too, so it's not 100% guarantee, but I think this is a very good, this looks very good for post-op day one.
So we should decompress in the OR this patient, or
Usually we do it at the slit lamp from
Slit lamp.
from the inferior paracentesis. You can just burp a little bit out.
Okay, thank you, bro.
But great job.
Thank you very much for your guidance.
Yeah, and a very, very difficult case. If you can do this one, you can do anything.
Okay, next case, please.
For the next case is the dissection with the background of pseudopachybolus keratopathy and post-secondary implant with Lamellar technique. On this morning follow-up, the right eye visual acuity was 6/30, pre-op over 60, with a normal IOP and clear cornea, graft attached, and one nylon suture, and with the bubble in the superior.
So this is a question for you. Where's the bubble? Where's the rest of the bubble? What do you think? Can one of the residents tell me where the rest of the bubble is? Because we definitely left more air than that in the eye.
Yes, Prof. Williams. So this is my case. So at the end of the surgery, we left about like 80% of the bubbles.
Yep.
But then today we only see like a very little part in the upper. And I don't think the anterior chamber is like have shallower because of the bubble pushing from behind. So that's why a little bit confused because it is SF6, but one day post-op is very little to do. The
Yeah.
graft is attached, but I don't think that there's a bubble to tamponade it.
So the rest of the bubble is in the back. And because the patient is sitting here, and because the eye gets bigger superiorly as you go back, it's sitting against the top of the eye, behind the lens. If you lay this patient down and have them look up, you'll see bubble. You'll see the bubble. It might actually even come around into the anterior chamber, but because they're sitting up, the bubble has slipped behind the lens and is sitting at the top of the eye. And it's very hard to keep that from happening in patients who are vitrectomized and who have a Yamani or a scleral fixated lens or something like that. What I like to do if I'm placing a lens on a patient that's getting a DSEC is I like to do an iris sutured lens so that the lens is sewn to the iris and blocking the pupil to keep the air or gas from going back. But given that the graft is attached, this is a good result. And as long as the graft stays attached, then that's great. And the DSECs will often stick even if the patient only had a few hours of bubble and then it went into the bag. A lot of times the DSEC will still stick. If it doesn't stick, you can add more.
Oh yeah.
And if it continues to not stick, you can actually put a suture or two in through
Itu
the
sama-sama jelek dua-duanya.
through the cornea into the anterior chamber and then up through the DSEC.
So how many suture usually? Four?
If you had to, you probably do 3.
Okay.
Or but I don't think you're gonna have to. I think this will clear as well. Again, the cornea looks pretty clear. That's a good sign. If the cornea were super hazy and edematous, then I would say less likely that it will stick. But I think there's a very good chance that this will clear and be great.
Thank you.
This looks perfect.
Thank you.
Also, a very difficult case, and you did a great job.
Okay, so the next is the PKP patient. The patient was actually done KLIL, IL exchange, PKP, and AMP of the left eye. This morning follow-up, the visual acuity was 1/600, the projection, the same as pre-op. And the IOP was height, 32 on Lamellar. The cornea clear, AMP not visualized, good graft host junction with 16 radial sutures. However, there is one exposed suture at the 7 o'clock and left suture at the 5 o'clock, and then 2 sutures at the limbal area at 6 and 7 o'clock, no loose or broken suture with good limbal graft attachment at 6 and 7 o'clock, no neurovascularization and pulling steaming. Do we need to devise the suture for today?
I'll give it to Dr. Tien.
So these loose sutures, you can, sorry, these exposed suture knots, you can often just rotate them at the slit lamp on the first day, anesthetize the patient, get some antibiotic going, and then you can rotate them. If, it's difficult sometimes to rotate them if they break and they're still side down negative, it's okay to leave it as well. But these sutures can be fixed. You can already see a lot more iris details on that first left picture. And it looks like the KLAO has kind of been accepted, is kind of still in place, and the con just nice and closed all around it. So, I actually have heard that this patient's bandaged contact lens fell out this morning, as well as their AMT. So I actually already saw them, and one thing I did is I put the bandaged contact lens back on, and then I did that little tape tarsorrhaphy trick we talked about 2 days ago. And the contact lens probably fell out because the fornix is the palpebral fissure is so large. So if we make the palpebral fissure smaller, hopefully that contact lens stays on and continues to protect the epithelium as it heals.
Yeah, and I think this looks really good right now. Obviously, the big question is, will the cornea epithelialize? And that's going to determine whether or not this continues to look good or eventually fails. But so far, I think it looks great.
Thank you, Dr. and Professor. We'll move on to the dog patient. The first one is the patient with the lattice corneal dystrophy. On this morning follow-up, the visual acuity was 6/60 compared to the 3/60 preoperatively, and the IOP is 11 with host graft junction appears good with a hazy cornea, edema, and definite faults. 16 multiple nylon suture line radially. However, we cannot see the bubble in the.
Were you able to visualize just to make sure that there wasn't a double anterior chamber?
Double intrusion.
Great. So I think this looks great, and it'll continue to clear.
So the second patient, so the dog patient, the visual acuity was 0.5/60 with pre-op 1/300 the projection with cornea edema, hazy, good graft host junction, 16 nylon radian sutures, and no broken sutures. However, the anterior chamber was appear flat. From my discussion with Dr. Farabi, do we need with anterior chamber appears flat with phakic lens? Should we do
Yeah, this is the dog in the phakic eye, Prof. So we can see it in the peripheral part is the peripheral cornea is a little bit shallow, and also in the middle part is shallow anterior chambers. And should we afraid about the risk of glaucoma in the future?
So I think the question is it flat or shallow? If it's shallow, I think it'll be fine. If you do have peripheral iris corneal touch, then I think we should put fluid in and try to expand the chamber. You can see that it's deep in the center, but and the pressure is at least moderately normal. So as long as there's no IK touch or iris corneal touch, then this is something that we can watch. Looking at the photograph, I can't 100% tell if there's iris corneal touch. So if there is, then we should just deepen the chamber with BSS. So it probably something I'd have to look at the slit lamp actually to be 100% sure.
Yes, we will bring the patients to the OR today. Maybe you can see by yourself directly.
Yeah, and that dog, probably some of that problem is one of my sutures. I nicked the the posterior, the patient's Descemet's membrane. And so I made a small hole accidentally in the Descemet's. And so I think there was a little bit of a leak there. And so it was harder to manage the chamber. So that's one reason why you want to be very careful not to put a suture through the Descemet's membrane.
Okay, thank you. Now, we want to ask about the post-operative protocol, Prof, for the endothelial keratoplasty. Maybe we have levofloxacin, prednisolone, and today we plan to give it 6 times a day, levofloxacin and prednisolone. And do you need usually need something else or adjust the doses of the medication?
So those look overall very correct. Of course, you'll be able to monitor the pressure much more closely and adjust the pressure medications accordingly. Initially, the steroid and the antibiotic sound reasonable, but often you can taper pretty quickly. I know you talked about sometimes that the conditions may not be that sanitary, but in the United States, we use the antibiotic only 4 times a day. So you can kind of use your own judgment for that. And the steroid drop, I agree, should be every hour for the first week. One situation I rarely run out of is the steroid drop and the antibiotic have preservatives. So you don't want to load the eye up with too much preservatives. So, but I think every hour for the first week is at least reasonable for that. The most important thing, though, is not necessarily the drops, it's the positioning. So for both of those cases, yesterday we used SF6, which stays in the eye about roughly just under a week. So, especially for the DMEC, we recommend kind of face up positioning with frequent breaks, but for about 5 days. Okay, and then the DSET attaches a little bit better, so we recommend 2 to 3 days. But often, sometimes we just use regular air, and 2 days are just fine too. But the positioning is very important in endothelial keratoplasty.
So do you give also the prednisolone hourly in the other keratoplasty or just in the endothelial keratoplasty? Hourly prednisolone.
So penetrating keratoplasty, I typically do 8 times a day, so every 2 hours. And I think it's reasonable to switch the DMETs and DSETs, which are looking pretty good too, also every 2 hours. Every 1 hour, every 2 hour, kind of based on how the cornea is curving. And both, I think all these cases so far, every 2 hours is actually reasonable.
Do we need oral corticosteroid?
The PK, I think we should, especially because he was already on oral steroid. I would continue that at least for a couple weeks to make sure the body is accepting that high-risk transplant, not necessarily for these EKs.
Okay, thank you, Dr. Tian. Is there any case? So do we have any question from the audience in Zoom or in the auditorium? No, we can conclude the meeting today. Thank you very much for the resource person, Prof. Lloyd, Prof. Dr. Tian and Dr. Sinasong. And I conclude this meeting. Good morning. Assalamualaikum warahmatullahi wabarakatuh.